Good afternoon, everyone, and welcome to today's Black Health Trust. My name is Dr. Ivan Walks, and we are so pleased that you are with us this afternoon. I would like, with no further ado, to turn it over to our founder, Dr. Randall Maxey.
Good afternoon, everyone. Thank you for joining us on this wonderful, wonderful Sunday afternoon. We have a very exciting speaker today, but there are a lot of things going on in our world of trying to inform people of health issues. And our speaker today is going to speak to one of the more critical issues that we know about, which is women's health and women's critical issues of breast cancer. She is a radiation oncologist. Dr. Iman Washington is an assistant member in the Department of Radiation Oncology at H.D. Moffitt Cancer Center and Research Institute. She's a member of the breast section in radiation oncology and the Moffitt Breast Program. She received her Bachelor of Arts in Chemistry from Duke, which didn't win the Sweet 16. And
That's wrong.
She received her MD degree from Duke University School of Medicine. She completed a preliminary medicine residency at Northwestern University McGraw Medical Center in Chicago, Illinois, followed by a radiation oncology residency at the Ohio State University. We welcome her. And Doctor, we're very casual on the show. We try to have some fun. Dr. Walks always criticizes me, but we welcome you, and the floor is open to you.
Thank you for having me. So today I'm going to focus on breast cancer screening for women in general, but specifically some considerations for Black women. Breast cancer itself is a very large topic, and so is screening. So the goal is kind of to talk about some common questions regarded to screening and recommendations. So I can share my screen here. Let's see. Can you see that okay?
Yes, we can.
Okay. So I figured I'd start by just providing a little context for women in general, kind of more of a bird's eye view of why we have screening guidelines in the first place. So breast cancer is the leading cause of cancer deaths in women worldwide between 29 and 59. The lifetime risk of developing breast cancer is the highest in North America. And in the US, it's about 1 in 8 will be diagnosed with breast cancer. So getting into breast cancer screening in terms of how it's diagnosed. So breast cancer can either be diagnosed because women present with symptoms, or because they've undergone screening when they didn't have any signs or symptoms and it was detected on imaging. So our goal is to catch as many women with screening mammograms prior to having signs and symptoms of cancer. So mainly that focuses on mammogram. So mammograms are low dose X-ray pictures of the breast. It's performed by gentle compression of the breast, which can cause some discomfort, but it's a short process. And it results in minimal exposure to radiation. So that's one of those things that comes up about what's the risk of mammogram, and the risk of mammogram is felt to be very low. MRI, which gets I'll mention some expansive discussion on MRI. We'll get a little bit out of the scope because that's such a big topic in and of itself. But for high-risk patients for breast cancer, MRI is part of the screening guidelines, and we'll talk about what does it mean to be high risk. Ultrasound is not typically used for screening, as in that's not an automatic image that's ordered, and an ultrasound is essentially a wand, also referred to as a transducer, that's placed on the skin with gel between the wand and the skin, and sound waves are transmitted and echoes are picked up, and that creates an image. So it can be helpful for further evaluation of something that's abnormal or potentially abnormal on a mammogram that the radiologist wants to get additional information about, and they will ask for an ultrasound, and that increases the overall detection rate when they're combined when there is an issue on mammogram, or if someone presents with a lump or a mass, then an ultrasound should be ordered in addition to a mammogram. It can be helpful for women with dense breast tissue in certain circumstances as well. So screening recommendations, how they're determined, and why don't all organizations agree on timing and start, and the timing to start and the frequency to obtain imaging. So there were a number of studies coming out over a series of time, about 15 years, that ignited a lot of debate, and multiple guidelines have come out since then from different organizations, some saying to start at 40, some saying to start at 50, some every year, some every 2 years. So there's no wonder that there's a lot of confusion about when screening should start. So, some of these are kind of my thoughts on why there's so much variability. Sometimes it's hard to tell how certain guidelines were determined by certain panels because it's not really transparent into how those recommendations came about. Those that say that annual mammogram should be starting at 40, the rationale is that saves the most lives, and it's using trial data. So clinical trials, studies comparing women who have undergone screening versus not undergone screening, and other information like that has led to that recommendation for women to start at 40. So why would a group be concerned about starting at 40 or suggest that timing may be of concern? So the concern is, what's the risk of overdiagnosis? So either finding cancer that would have been presented later and not interfered with whether or not someone died from breast cancer, or maybe a cancer that, if it had never been picked up, would not have impacted this woman's lifespan. That's the concern. The data suggests that more women are saved when starting at 40. The other concern is, what about a false positive mammogram, which means that the mammogram suggests there's cancer, but then there's actually no cancer, leading to more tests and visits, biopsies, anxiety. So that has actually been looked at, right? How do women, when we incorporate the woman, when we incorporate patients, how do they feel about a false positive mammogram? So studies suggest that they're aware of false positive mammograms, and they feel like that's acceptable, an acceptable thing that can happen with screening mammograms. So NCCN, so where I work, we believe in mammograms at 40. That's something that's very common amongst cancer centers. So rather than go through every single organization and what their recommendations are, which I think can be a little bit confusing, and we've kind of talked about justification for what I'll talk about, which is the NCCN guidelines. So NCCN is the National Comprehensive Cancer Network. So it's a non-for-profit, 32 leading cancer centers devoted to patient care, research, and education. Their guidelines are evidence-based, and oncologists widely use these guidelines, just to give some context. So these guidelines, and they were recently updated last year to provide more clarity, suggest that annual screening mammogram should start at 40, and this is for an average risk woman, and we'll kind of talk about average risk versus higher risk. So an average risk woman at 40, clinical breast exams starting at 40, those women younger than 40, but older than 24, so 25 to 39, clinical breast exams every 1 to 3 years, and then higher than average women may benefit from earlier screening and additional screening. So these guidelines always get, it always ends up being a lot of words on the page. So I'll kind of talk about the high points. So basically, screening is referring to an asymptomatic woman. So not having any signs or symptoms that are concerning for cancer. If there's concern, there's a lump or etc., a diagnostic mammogram should be done. So this is just focusing on asymptomatic women. Of average risk, we just kind of talked about how women at 40, an annual clinical encounter of screening mammogram with tomosynthesis is recommended if it's available. So tomosynthesis or 3D mammograms improve how well the radiologist can see the breast. And for women of increased risk, we'll go through that in a second, but there's some additional recommendations on timing and adding a breast MRI. So how a woman figures out that she's of higher risk. There are multiple risk models that are available so that women can calculate what their lifetime risk of breast cancer is. So recommendations have been made, because there are a number of them, to include or use a risk model that has is heavily weighted in family history. There's other women who have been genetically tested and say they're BRCA positive, which is a mutation that puts you at a predisposition to an increased risk of breast cancer. So those women are considered higher risk. And then women who've had thoracic radiation, so that's radiation to their chest at a really young age, is also included in that group. But for Black women, the recommendation by the American College of Radiology is that by the age of 30, you should have an assessment on whether or not you're average or at increased risk for breast cancer. Okay, so that's a talk to your physician about one of these risk models so you can figure out by the age of 30 what your risk is. Part of the recommendation of what to be done at a clinical encounter is to reevaluate, one, how you're doing, but also your medical history, right? Because with time, you find out that other family members or a family member may be diagnosed, and that needs to be included in the risk assessment when maybe prior years it hadn't been included because that hadn't happened yet, which is another kind of brief spin-off point about how important it is for us to share our medical history with our family members, because this information can be relevant to them as well. right? So just kind of being open about that is important. And I essentially just spoke about this, and this is that there's different tools and they can create different estimates of risk. And it's important that family history on both sides be included in the risk model that's being used. So what's included high risk in these risk models is a lifetime risk of at least 20% of breast cancer. And for the women that fall into that category, their clinical encounters are every 6 to 12 months. And if you're not sure about whether, you should be at the 6 or the 12, having that conversation with your physician, in terms of your comfort level and what's going on with you, is an important thing to do. So it's to begin when women are being are identified at increased risk, but not prior to the age of 21. Consideration can be given to a referral to a genetic counselor, or being referred to a breast specialist, or a breast clinic, that sort of thing. And then there's an annual mammogram as before, but this also includes an annual breast MRI. So that's to begin 10 years prior to when the youngest family member was diagnosed with breast cancer, but not prior to 25, or at 40 if that comes first. So whichever one comes first. So just to touch on a little bit about disparities in breast cancer and why this is important for all women, of course, but specific focus should be given to Black women. The mortality rate of breast cancer remains higher for Black women compared to Caucasian women. The rates of development of breast cancer and death related are reported to be lower in other women. Black women tend to be diagnosed at a younger age than other ethnic groups. And Black women are twice as likely than other groups in the US to be diagnosed with triple negative breast cancer, inflammatory breast cancer. So a triple negative breast cancer and inflammatory breast cancer are two of the more aggressive types of breast cancer. Triple negative refers to, we characterize breast cancer as, is it hormone receptor positive? And that specifically refers to having an estrogen receptor or progesterone receptor. And we look at the HER2 neu to see if it's overmaking the HER2 neu protein. So essentially, without kind of getting too much in the weeds about that, those three characteristics are how we define a breast cancer. Does it have those features or not? And that determines what treatment options are available in terms of medication. It may influence the order of treatment. And it also gives us information about how aggressive the cancer can be. So a triple negative breast cancer is more aggressive. So that's it, hormone receptor negative, HER2 negative breast cancer. An inflammatory breast cancer is a clinical diagnosis where typically the skin is involved, and it's a more aggressive breast cancer. So just briefly on dense breast, because that comes up, like what does dense breast mean? So the breast density reflects the amount of fibrous and glandular tissue in women's breasts compared to the amount of fatty tissue. And for unclear reasons, women with dense breasts also have a little higher risk of breast cancer. There's no difference in mortality for breast cancer patients that have dense breast, and mortality being they're not more likely to die from breast cancer. Women who are more likely to have dense breast tend to be younger, pregnant or breastfeeding, taking hormone replacement therapy, or have a lower body weight. So in 2019, Congress passed a national breast density notification law so that it has to be reported on the imaging report that whether a woman has dense breasts or not. So dense breasts can make certain lesions harder to see on mammogram, which is why we take note of it. And for women who are at a higher risk, this is something to consider. And talking a little bit more about breast density and size, because both of those commonly have been asked, right? So are there limitations to breast size? Or some women who can't get a mammogram because their breasts are too large? And mammograms can be performed on women of all sizes. So women with very large breasts may require some additional imaging, but should still get screening mammograms. As far as breast MRIs are concerned, very large breast women can get breast MRIs. They may need to be repositioned so that the images are good for the radiologist. And there's different weight limits to the machines that do MRIs, so the MRI table. So that's more the overall weight of the person, but very large breasts can be imaged. And so for women of no personal history of breast cancer, since we're talking about screening, we said that we need to start with the risk assessment. If they're at high risk, they need a breast MRI. Otherwise, it's a screening mammogram. At average or intermediate risk, an abbreviated MRI can be obtained if there's after a discussion and for other things that are being considered by that clinician and patient. So despite the variability in some recommendations, although, I've talked about what NCCN and cancer organizations feel the screening should be, as well as the American College of Radiology and some others. But Black women in particular, it makes more sense to adhere to such guidelines as NCCN rather than ones that suggest less frequent screening or screening later, because a failure to address groups that have a higher risk of breast cancer at a young age, or at a higher risk of breast cancer mortality, meaning death from breast cancer, which is a situation that applies to Black women, leads to concerns for potential in making racial disparities in breast cancer outcomes worse by not acknowledging that and not doing more conservative screening. And screening risks tend to be overstated. So it's a very low risk process to get screened generally. So those are kind of my high points on breast cancer screening. There was one other thing that comes up that I think is also important to talk about in terms of treatment. So part of the fear of undergoing screening and finding something is then, the need to undergo treatment for breast cancer. So the treatment for breast cancer, the goal of screening is to detect breast cancer at the earliest stage possible. Women who are detected earlier have very, very, very good survival rates, right? So they're in the 90s. for an early stage breast cancer. So we want those kind of outcomes for as many women as possible. The later the stage, the later the diagnosis, the survival rates start to go down, and the degree of treatment required to try to take care of the breast cancer, right? The treatment gets more aggressive. So those are the reasons to get screened. There is sometimes a common misconception that if breast cancer is found, then women have to get a mastectomy, which is to remove the entire breast, or that if they don't get a mastectomy to remove the entire breast, that they're not going to do as well as women who get a smaller surgery. And we have very, very good data for years and years at this point, very large trials with long follow-up, that if a woman is a good candidate for breast conservation therapy, meaning having a smaller surgery, then when radiation therapy, which is high energy X-rays directed at the breast, so a smaller surgery with a lumpectomy, which is just removing the tumor, plus radiation, gives women just as good as outcomes as if they have a mastectomy when they're good candidates for that smaller surgery. So still being able to maintain a breast and have a breast is a very reasonable and good option for women who are diagnosed with early stage disease, or have been told by their surgeon that they're good candidates for a lumpectomy followed by radiation. So I think those are a couple things that I wanted to address in terms of treatment.
Well, thank you so much. This is a lot of information that's extremely valuable. Let me just ask you the first issue.
Yeah.
And I know this talk is mainly about women's health, but early on in my practice, I saw a gentleman who had breast cancer twice.
Mhm.
Do you see much of that? And is there any, I know you mentioned 1 in 8 occurs in women.
Yeah.
Male breast cancer.
Yeah, so male breast cancer is far less common. So that's more like 1% of breast cancers are in men. So did that patient have, or did that gentleman have any genetic testing done?
That was almost 30 years ago, so no, he didn't.
Okay. Yeah, so now doing genetic testing for a gentleman who has breast cancer, I think would be important, some genetic counseling for that gentleman. So we do see it far less common, but it does happen. Okay.
And 2 other questions before we go to Dr. Waltz. You mentioned that some women have fear of a mammogram because they don't want to get bad news, and I understand that. Are there any possible complications of the mammogram itself that they could fear of that?
So I think that the biggest thing with the mammogram in terms of what's unpleasant about it is there is compression to the breast tissue. And so that can be uncomfortable for women, or, cause some pain, which would be temporary and brief. So that process is overall tolerable. And that brief discomfort is not a good reason not to undergo breast cancer screening, but that's going to be the main complaint, I think, of the process.
All right, well, thank you so much. Dr. Waltz?
Thank you so much, Dr. Washington, for this talk. There are several questions and comments in the chat. let me start by just, I'm one of those people that just goes right to the bottom line. It sounds like if there is anything that you feel is different about your body, you should get to your doctor and say, doctor, what is this? I feel something different. I see something different. I'm not sure what this is. Is that a fair way to just bottom line everything at the beginning?
Yeah, yeah. So that kind of also speaks to questions about, self breast exams. So there's also kind of a lot of confusion on whether women should be checking their breasts or not. And that comes from the fact that there's no good studies that show that women doing breast exams is going to affect their prognosis. However, the rationale is that women should have a good idea of what's normal for them. So if something's abnormal, they can report it to their doctor and have that discussion and potential workup. And so those that recommend just doing routine breast exams acknowledge that data, but the goal is just to make sure that women are familiar with their breasts so that if something changes, they can identify it and talk to their physician about it. So that kind of speaks to your point that it's always appropriate to say, I don't know if this is right or wrong, or I don't know if this is okay or normal, but to have that discussion with your provider so they can evaluate you appropriately and talk you through, kind of what's normal and abnormal in terms of what's going on with your body.
And so as a follow on to that, there was a comment in the chat about the Black Women's Health Study Assessment that was developed for primary care doctors to administer. One, is that something with which you are familiar? And then two, you're an expert in this. This is what you do. Is it reasonable for us to expect that every primary care person has the information about breast exams and timing and the low risk and high risk and all of that? Oh, I think Dr. Washington, did we lose you? I think Dr. Washington is frozen for the moment. What I'll do is I'll just continue with the question in case Dr. Washington can hear us and then can come back. It's a significant issue. This conversation we have many times here on Black Health Trust about everyone needing to have a physician or a practitioner that they go to. I think Dr. Washington came on again, but is muted. Simon, can we get her unmuted? There we go. Dr. Washington, you're back. We're going to try to get you unmuted. This is what Simon does to me whenever I either drop off and come back or I come in late. And for me, it's punishment. There we go. Go ahead.
Okay, sorry, I just kind of got disconnected there. So I got disconnected in the middle of a second question. One was whether I was familiar with
the Black Women's Health Study Assessment. And then because it's meant to be administered by primary care docs, are we, I don't know what the correct term is, are we assuming that all primary care docs are going to be able to give the comprehensive kind of assessment with respect to risk and timing of assessments and that kind of thing? Because you're an expert. This is something that you know a lot about. What about all the other docs that are out there?
Yeah. So that assessment that you're referring to, I'm not familiar with. So as a radiation oncologist, everyone I see already has a diagnosis of breast cancer.
Okay.
So, so it's a little bit different in terms of the tools that, I use in my practice. I think that this being kind of a combined effort between family practice physicians and OBGYNs, anyone involved in early screening is important. I think if utilizing the NCCN guidelines is a really provides some guidance to what I think is a complicated issue. And I think if a patient is more complicated, it's very reasonable for them to either see a genetic counselor or, have a consultation at a breast specific clinic, because there is a lot out there. So I didn't get into, there's certain genetic syndromes that if it runs in your family, that changes your risk and things like that. So it can get a little bit more, more complicated for certain patients.
Dr. Walks, Dr. Stephen Thomas put some interesting comments and observations in the chat. I wonder if we can either unmute him or can you read his question?
I know the last couple of weeks we've had Dr. Thomas has had some challenges with his technology. So
I think they do have electric in Maryland, though, right?
Dr. Maxey, we have great electricity in Maryland. These California people, Dr. Washington, just because the reservoirs have filled up, now they just talk bad to everybody else in the country. But
can you read his questions if we can unmute him?
I can. So Dr. Thomas put a comment in with respect to literature giving us facts and what do we do with the information. And basically it's the Black people are more likely to die from most cancers and to live the shortest amount of time after a cancer diagnosis than any other racial and ethnic group. So I'm guessing that particular comment is more in line with we have information, what are we doing with it? And then to follow on, Dr. Thomas put in comment, why is it that far more Black women are at stage 3 breast cancer upon first diagnosis compared to white women? And how might we address the social determinants of health? For example, the literature states that the reason for racial disparities is largely driven by decades of structural racism, leading to a higher risk of lower socioeconomic status. So there, and then also Dr. Thomas talked about the higher rates of breast cancer in Black men as opposed to other groups. So it is a litany of important comments about the racial disparities, which you mentioned, Dr. Washington, and then Dr. Thomas's last comment, I think, has to do with how might physicians deal with individuals going through transitions, for example, transitions from male gender to female gender or others. And should a trans man born with female breast tissue follow the screening guidelines for women? So there are a lot. This is why every time someone talks about the Black community, I just quietly go, really? You think there is one Black community? We are a diverse set of communities with a diverse set of backgrounds and a diverse set of challenges. So this is really brought out in Dr. Thomas's comments.
Yeah. I mean, those are a lot of really good questions and a lot of big questions, right? And I don't think that we have all the answers, or I know for a fact we don't have all the answers, right? So, in terms of disparities, when you look at the literature for breast cancer disparities in Black women and why might that be the case, you get a lot of answers of things that may contribute, which creates a really complicated web of how do we use that information to decrease these disparities. So there's data for there being an access issue, right? A utility issue when there's access, a quality issue.
Right.
There's, data for certain potential genetic predispositions that applies to Black women and certain types of breast cancer. There's data on, obesity and weight. Granted, that's kind of a beast in of itself to talk about, because there's that data is not super straightforward. And then we look at other kind of breast cancer related risk factors in terms of lifestyle, right, that we have to take into consideration, like exercise, smoking, alcohol consumption. And some of these things also overlap with social determinants of health and what that means to be more low income in terms of what your risk factors are, or behaviors that are more common. So it gets to be a very, very complicated issue. And so, I think one place to start, there's the advocacy towards, increasing access. There's encouraging the women that we do interface with to utilize the resources that are available to them. And part of that is educating women and dispelling some misconceptions. So, one that I've heard is, well, no one in my family has breast cancer, so I can't get breast cancer, right? But we know that most women diagnosed can't identify, if there's not a genetic predisposition that we're aware of specifically in that patient or that person. And breast cancer is 1 in 8 in the US because it's common. So encouraging women to live healthier lifestyles in general, right, with the exercise and healthy eating and not smoking and limiting alcohol consumption. I mean, I think those are all things that we can do to kind of get started on the issue, but it is a large one. In terms of Black men being at higher risk than white men, that's consistent with Black women being at higher risk for than white women. And as far as the transgender population and those born with breast tissue are advised to undergo screening.
So
Let me go.
go ahead, Dr. Maxey.
Let me just ask a further question. Another patient that I had recently was a 73-year-old lady who had been treated for breast cancer with radiation.
Mm-hmm.
And she developed an angiosarcoma
Mm-hmm.
of her mediastinum. Have you seen much of that?
So I have. It's a not common but possible result of undergoing breast radiotherapy. So presumably she was treated much earlier in life, and then her diagnosis of the angiosarcoma, you're saying, is when you saw her in her 70s. Is that correct?
Correct.
Yeah. So there's a risk of second cancers related to radiation therapy. When we look at that risk as measured on the order of decades, the risk of that second cancer, such as what you're describing, an angiosarcoma, is less than 0.5% per decade of life. So the risk on an individual patient level is very low. but it's not impossible. And that's something that I talk to all of my patients about when I'm going over, the most common and then the least common potential side effects from treatment, right? So the most common late side effects of treatment when they have an intact breast is cosmetic related concerns and how the tissue feels and that sort of thing. That's going to be the most common stuff. Higher risk or more serious complications fall into the less common bucket.
Okay, we have a number of our advisory members on. There's Dr. Johnson, Dr. Coombs, and Dr. Sherrod. I wonder if they would have a comment while we still have time.
And Dr. Maxey, while we're getting some of them unmuted, Fred Sims had a couple of comments in related to let me get to it here, related to studies that have shown that women using hair straightening chemicals may have a link to breast cancer. I don't know if that's something that you've come across, Dr. Washington, or and also some comments about whether or not there are certain parts of the country where either through environmental factors or socioeconomic factors that you find cancers are more common in Black folks than in others.
So there's certainly an environmental link to increased cancers in certain areas. So I can't speak to specifically, what those communities are. Oftentimes there's a history of some environmental exposure or something like that. But it's certainly, I think, worthwhile to have an idea of whether or not those concerns apply to any of the populations that you serve. And in regards to kind of other risk factors for breast cancer, there's a lot of data out there. There's a laundry list of things that have been shown to potentially have some sort of association, but difficulty drawing sort of either a causal effect, just because that data is so hard, so hard to analyze. And that, to be honest, like keeping up on what that laundry list of things are, I review the literature periodically. But oftentimes there's a concern, but the data is on the kind of the vague side for drawing conclusions, unfortunately.
So thank you so much. Are any of those individuals I mentioned unmuted? Dr. Johnson, Dr. Coombs, Dr. Sherrod?
I don't see any of them with their hands up, Dr. Maxey, and none of them at this point are unmuted. Dr. Johnson is. Here we go. Hello, Dr. Johnson.
Hello, good topic today. I guess I just have a concern that Dr. Thomas mentioned in the chat about the Susan B. Komen. And again, this is more for discussion than it is for Dr. Washington. It is a popular, I know that around Mother's Day, many of the women that I know that are breast cancer survivors have walked in the Susan B. Komen walk. But Dr. Thomas puts in the comments that Black women don't feel included in national health level promotion campaigns. So should Black people be given donations to the Susan B. Komen cancer campaign? Now, I don't know, but I would imagine there are people on this webinar today that have participated in. I know that I've given my donations because of the number of women that I know whose lives have been impacted by breast cancer. But I don't have an answer to that question, but I would like to hear what this group has to say about that observation. Is that true that Black women aren't being served by these advocacy groups? That's my comment. I'm done.
Thank you. Is Dr. Sherrod available?
Dr. Coombs and Dr. Gibson both have their hands up for a comment.
Okay, let's go to Dr.
Dr. Coombs, go ahead.
Yes, thank you so much. I want to really show my appreciation for this discussion. It's timely. One of the issues that I've seen over my years of practice is what happens when someone is in the midst of getting surgical treatment for breast cancer. And I've actually had to seek out second opinions from breast cancer surgeons based on a number of things. One situation is where women have had previous plastic surgery and had tumors, cancer that develops in the setting of a prior plastic surgery. It really is important to have someone really examine your mammogram. In one situation, they thought they were going to do a simple lumpectomy, and it turned out the patient needed a complete mastectomy because there was actually evidence of cells in the region where the mastectomy, where the reduction mammoplasty had been done. So one of the issues I really would want to stress is that there's this whole idea that anyone can do breast surgery, but there are preferred providers. Any general anesthesia, any general surgeon may try to do breast cancer surgery, but you really have to be careful that they're in cutting edge and up to date. It's a discipline like any other discipline, and you have to look at the performance of the practitioner, the provider who's actually treating you. And so I've seen situations where someone's a general surgeon who has not kept abreast on breast surgery research, and they will do a procedure that later on someone says, well, why was that done? And they were not really on the cutting edge of what the literature has said. And we know from the Canadian study that, everyone was doing the radical mastectomies at the very beginning, and then we had some kind of mid position after someone analyzed the research, and the research was somewhat unfounded. So I think one of the things coming from a family that's at high risk for breast cancer is really looking at, once you get into the pathway, the clinical pathway for treatment, although the pathways are fairly consistent, the individuals that are on the assembly line are not. So that's the only thing I want to stress. Thank you.
Thank you. Dr. Gibson?
Yes, I have one short question, actually. How do we describe a patient who is high risk? I've heard high risk mentioned several times, but I'm not sure I know what a high risk patient looks like, if we could have that addressed.
Yeah. So let me go back to
It was one of your early slides.
yeah, let's see if I can share that again.
Sorry about that.
That's okay. Well, I have slides here. Easy to go back to. All right, let's see. All right. So high risk can be, we talked about, so any woman who has at least a 20% lifetime risk of breast cancer is considered high risk. And that 20% would be determined by, there's different models for risk assessment. The models that some are specifically more recommended by NCCN. The models that are considered appropriate are heavily weighted on family history. They include a lot more family history. So that's one thing to included.
Okay.
Women who have undergone genetic testing and they're BRCA positive, for instance, so they have some sort of genetic predisposition for breast cancer, are considered high risk. Women who had thoracic radiation therapy between the ages of 10 and 30 have specific screening guidelines and are considered high risk. the one note to make for Black women in general is all Black women should be assessed by the age of 30 on what their risk is.
And
Wow.
with dense breasts, they're higher risk too?
So dense breasts are at a somewhat higher risk of breast cancer. They don't have a higher risk of breast cancer mortality. So not more likely to die from breast cancer. The discussion on density, so it may be that something that is seen on mammogram needs further evaluation by an ultrasound. The discussion of, additional screening for women with dense breasts is a complicated one. And a radiologist probably would do a much better job than I would on kind of the ins and outs. Part of what's complicated is that information that we have has not influenced screening guidelines. It's left to the discretion of the conversation between the patient and their provider when they have very dense breasts. Women who are at a higher risk of breast cancer, that would be amongst the reasons that kind of add to making sure that we do the supplemental or specific screening for those women as well.
Thank you.
So much.
And Dr. Maxey, Dr. Sherrod is unmuted now.
Okay, Dr. Sherrod?
Yeah, can you all hear me? Because I lost my screen, but can you hear me?
Yes,
We can hear you. Yes, ma'am.
Oh, okay. I just want to commend Dr. Washington for an outstanding presentation. And I also wanted to, there was a question asked about how much do primary care physicians know about the information that she gave us today. And I just want to emphasize that it's very important for the primary care physician to know at least the screening schedules, because one of the first projects of the Association of Black Women Physicians, which we started back in 1982, was breast cancer screening. And what we found from the data at that time is that most women, if told by their physicians to get a mammogram, they would go and get the mammogram. So I think it's very important for primary care physicians to emphasize the importance and know the new testing or risk testing assessments that she informed us of today. And also concerning Black women, their cancer tend to be more virulent. And this is directed at the question about why is it that Black women are usually in stage 3. And I'm not sure this is the right answer. I think it's multifactorial, but I think one of the problems is that usually cancer is very aggressive. So it's very important for Black women to be on top of self-breast examination and getting the mammograms. And if their mammograms show up positive, they need to get access to care early on, because that also can be an issue of once they're diagnosed, there can be a delay in them getting what they need once they get the diagnosis.
Thank you, Dr.
But excellent presentation.
And Dr. Maxey, Fred D. Sims is unmuted as well, and he had put several comments into the
Okay,
chat.
Mr. Sims? Is he unmuted?
Yes. Fred D. Sims. Oh, he may have stepped away, Dr. Maxey.
Okay, well, we're at the hour when our program is almost at an end. I'm wondering if you have any final comments or thoughts you'd like to leave with our audience, most of whom are lay, even though we have some physicians speaking out. Dr. Washington?
So I think it's important to stay on top of all health maintenance, to get your mammograms by, at the age of 40, and to have a risk assessment prior to then by the age of 30 to figure out if you should be screened earlier or with supplemental screening. Have a don't feel shy about talking to your provider about what may be going on with you and understanding whether that's normal or abnormal or needs a workup. And also to understand about what resources are available to you should you have certain, constraints or concerns about healthcare. And I'll just give an example, like at my institution, we have charity care, and I don't know, it's how many women in my vicinity, right, know that there's charity care available, or you can go online and see where you can get your mammograms, right, when you're uninsured, or that the fact that your insurance should be paying for your mammograms, that kind of thing. So there was a comment in the chat about kind of empower yourself about what resources are available to you, and ask questions about your health.
Well, I thank you a whole bunch, Doctor, for your presentation today. We learned a lot. Dr. Walks, do you have some final comments?
My first final comment is just really appreciate you being with us, Dr. Washington, and the level of scholarship, the level of caring actually shows very, very well. So we appreciate that. My comment around this topic is one that I make so many times. We doctors are great at telling folks what has happened. We can look at the research that has happened. We can look at the research that may have happened just yesterday. I think we are not as good at our crystal ball part of it, predicting what's going to happen. And so I think it's very, very important that Dr. Washington told us that the current guidelines were updated a year ago, right? So if you read all about breast cancer 5 years ago and didn't read about it a year ago, or your doctor read about it 5 years ago and not a year ago, you may not have the good information about what is your particular road with respect to keeping yourself safe. Health stuff changes a lot. That's why Dr. Maxey's here every Sunday with the Black Health Trust. There's information that comes up frequently. The last thing I'll say is this: in the chat, there was a comment about Beyonce Knowles' father and Richard Roundtree having being men who have been public about having breast cancer. We did in DC a program with Urban Magic Johnson and Richard Roundtree on men's health. Richard Roundtree came and talked about the breast cancer, and that was in 2000. That's 23 years ago. So we as a community, if we are one community, have known that these things are at risk. We are at risk for these things for a very long time. And the fact that we continue to not do as well as other groups says something really important about the work that Dr. Thomas does, being out in the barbershops and being out in the community, getting folks information and helping folks empower themselves with information. So I just want to underscore what Dr. Washington said about how important health maintenance is for every member of whatever community we're in. That's it, Dr. Maxey.
Thank you so much, Dr. Washington. Again, Dr. Washington, it's been great with you on today. I learned a lot and got to do a lot of pre-reading. I think everybody did. And for everybody else, we'll be back next Sunday and every Sunday thereafter. The Black Health Trust, we continue to try to get information to our communities of color. Thank you. And Simon, thank you again for being so efficient. Have a good day, everybody.
Thanks, Simon. Take care.